Good morning, delegates and friends. Uh, Being the first session of the day, I think we are mostly the speakers who are here. Quite understandable after a hectic evening cultural program and things like that. People are still sort of waking up and having their breakfast probably. So we'll start the session. This is regarding Phakic IOLs. In fact, I heard there's a wet lab being conducted by Star in one of the stalls. When I asked them what is the reason, because earlier it was like ICLs are only provided to people who are accredited. So 20 years back, there were very few ICL accredited surgeons in a city. So now probably they want that hesitancy that is associated with phakic IOLs. There are a lot of surgeons who are willing to take it up, but then quite a few of them are, a little hesitant how to handle them, how to load it, how to inject. So when most of the videos are shown, people talk about the risks and difficulties of doing the surgery. Actually, it's a very simple procedure because unlike cataract, you don't have to spend too much time working with the machine or anything like that. You just put in the implant. So today we are having we have four speakers. In fact, Dr. Mathew is laid down with fever, so he couldn't make it. So that topic also, I've borrowed his slides and I'll present a few slides from that. So we are going to talk about just not the foreign implants, we are also talking about the Indian implants. We have some of the best surgeons in South India and Kerala. And special welcome to Dr. Anand from Coimbatore. He's a senior surgeon in Lotus Eye Care Hospital, Coimbatore. I was also working there till 2006. And he's been there for quite a long while. Welcome, Anand. And Dr. Jason, one of my gurus, teachers, guides, a brother to me. Any time of the day, even in the night, I can call him to find out what I need. If I have any difficulties, I always discuss with him. Such a humble person that I have known. So he's here to give his views regarding the Indian lenses like IPCL, which he has done in hundreds probably. And Dr. Jairam is the owner, the founder and director of Precise Eye Hospital, Trivandrum. They have quite a few branches all over the southern part of Kerala, and he's operating in most of the centers of Precise. Welcome, Dr. Jairam. He probably is the person who first showed me refractive, like even LASIK and ICL when I started. Jairam actually, even now he shares his views whenever I have a doubt regarding all these surgeries. Even cornea, he's a good cornea surgeon. So we'll get to hear from him regarding Star ICL and his experience regarding that. So let's start the session. First is an introduction regarding phakic IOLs, which will be dealt with me, and then we'll go on to Dr. Anand after that. So I just would like to give a kind of introduction here regarding what phakic IOLs are, and a little about the refractive surgery. So basically it's a reshaping of the cornea that is done in all laser surgeries. And Jose Baraka was the first one way back in 1948 to show the concept. Like, he did scraping of the cornea, and later with microkeratomes, he did the surgery. Later on, radial keratotomy by Fedorov. You would have heard of him. In Russia was the next kind of refractive surgery that was very much prevalent, where you make 90% cuts in the cornea, multiple cuts, from 8 to 16 cuts are made. And then, you make the central part of the cornea flat. And Payman patented the laser that could reshape the cornea in 1989. But FDA approval for LASIK came quite late. That was in 1998 that the company called Laser Sight Technologies came out with LASIK, which was approved by FDA. So the other LASIK, the laser-related procedures, as you know, are PRK, transepithelial PRK, LASIK, and EpiLASIK and SMILE, as you know. And also intrastromal corneal rings intacts can be done to flatten the central cornea. So these are the other procedures that I just want to mention. And then earlier, just before LASIK and all the phakic IOLs came, we used to do lens extraction with implantation of different kinds of lenses, monofocal and also multifocal IOLs. Extreme powers, of course, multifocals are not available, but this was an option long time back, and even now, if all these gadgets are not available or the phakic IOLs are too expensive for you. So LASIK came with a lot of risks as well as disadvantages like overcorrection, regression, flap-related complications, and extreme change in the corneal shape. So it was a sort of irreversible kind of change that was happening in the cornea. And then post LASIK, like if you get an eye with cataract, even IOL calculation used to be difficult. So all spectacle powers above 7 or 8 where LASIK could not be done, this was the alternative. Phakic IOLs came into existence, where cylinders also can be corrected either in combination or in isolation. So different lenses that came into vogue are, as mentioned, it could be placed either in the anterior chamber, or it could be an iris clip lens, or it was a posterior chamber lens that was to be kept as a phakic lens. So these are the different lenses that we have seen over the last 20 years. Verisys IOL, again FDA approved, was a iris claw lens. Quite a few eyes were done. A lot of corneal decompensation, lens-related problems like losing grip on the iris and the lens getting dislocated in the anterior chamber, and all the complications related to that. Plenty of them were there. Then the angle-supported AC IOLs that came out around 2009. It died fast within a few months. I think India hardly had any of these lenses implanted, very few, if at all. And then the PC IOL, that is star ICL, is what has been used over the years, and it has been refined. The design has changed a lot, and that has almost come to be very established. So the indications are the age, anything above 18 or 19, when the refraction has become stable. And the anterior chamber depth should be about 2.8, angle more than 30 degrees. Corneal endothelium should be healthy, and a mesopic pupil size of less than 5 millimeters is ideal. So these are the contraindications. Any anterior chamber inflammation, glaucoma, macular scars, all these are rejects. You can't go do such an expensive surgery where the outcome won't be good. And also systemic diseases like diabetes, connective tissue disorders, and autoimmune disease. So these are the formulas that are followed in ACIOL and PCIOL. And often what we do is we take the measurements and hand it over to the company. They come out with the custom built kind of lens that is best for the eye that we are going to do the surgery. This is a picture of the anterior chamber angle supported lens, and this was brought about by Acrisoft, and 4 models are there depending on the size of the white to white. And this is the design of the Verisys lens. It's a single piece PMMA lens. the wound should be around 5 millimeters or slightly more than that. And so the scleral tunnel is what was preferred. And then this is the Star Vision ICL. It's a column that the company has come out with, and it's a lens that rests in the sulcus behind the iris, and it's implanted through a 3 millimeter incision. So the steps that are very should be taken with caution is, like, do a good refraction, a preliminary workup as you do in laser refractive correction, including topography, specular microscopy if available, good dilated fundus examination by your retina surgeon, and the pupil size is measured, and white to white distance is also measured, and make sure that it's not a dry eye that you're operating on. Intraoperatively, loading of the lens is to be done with a little care, because it's a very ultra thin lens, and also the tunnel size, as I mentioned, should be 3 millimeters or slightly more, so that the nozzle can be introduced into the anterior chamber before the injection of the lens, and under normal viscoelastic HPMC 2%. Gentle unfurling of the lens in the anterior chamber and fixation, that part is also a little, has to be done with care, so that you don't injure any of the structures inside. And if need be, a peripheral iridectomy was done till the new lens, new model with the central hole in the lens came out. Centriflow it was called, and that actually we don't do a peripheral iridectomy anymore. So post-operatively, one has to follow up for glaucoma, any signs of ill-fitting lens. A vault has to be checked, and the IOP has to be measured over the next few months, and probably a 6-monthly follow-up for IOP check and specular microscopy is what is required even post-operatively. So risks are, as already mentioned, glaucoma is a probability if there's an ill-fitting lens, the vault is too much. Iritis, if the haptics are going to rub against the iris, and pigmentary dispersion and such issues are there. And endothelial cell loss is always a possibility. So one has to be careful, following up the patient and make sure. But then it's been at least 10 to 15 years since the first few lenses were implanted, and most of the patients are doing perfectly fine. Retinal detachment and then dislodgement of the lens, as in the case of iris claw lens. So it's turned out into a major boon, and it's a reversible procedure. It's a major advantage in high and extremely high myopes, hypermetropes, and astigmatic eyes, on which laser surgery is not possible. Thank you very much. So Dr. Anand will talk about the design of the lens that has stood the test of time, that is Star ICL.
Good morning, sir. First of all, thanks to Jacob, sir, for giving me this opportunity to be part of this instruction course. And the topic given to me is the design, the make that has stood with time with Star ICL. So, I've been the speaker and high volume columnar surgeon. No financial disclosures. I have a special love for this material columnar since the day I started doing this ICL surgeries. I think Dr. Jacob has told about the evolution and how the phakic IOLs evolved. These days, any phakic IOL means it should be between the iris and the lens. And any phakic IOL, if it has to be ideal, I always feel that it should be non-inflammatory, it should be non-immunogenic, it should not induce cataract in the patients, it should facilitate easy aqueous flow. The thing of glaucoma should not happen whenever we implant a phakic IOL. That's how the lens has to be designed. And the most important is the make should be in such a way that the refractive index of the material with what we make this phakic IOL should be closer to the natural crystalline lens. This is the one which decides the quality of the light which passes through the material. As soon as we tell Phakic IOL, the first and the foremost thing comes on to the people's mind since last 20 years is its collamer, because this is the only biocompatible material that can be placed within the eye. There is no other biocompatible material that can be placed within the eye. This collamer is made up of collagen and 60% hemacopolymer. See the beauty of this material. It is hydrophilic. It's almost having 35% water content. And it has got a inbuilt UV blocking chromophore. The light transmission is around more than 99%. The natural crystalline lens refractive index, the nuclear index is around 1.43, but collamer's refractive index is around 1.45. Why this collamer is non-inflammatory? Because naturally each and every human being has got a material called as fibronectin. This fibronectin goes and coats the collamer once we implant this phakic collamer material. Once this fibronectin goes and coats the ICL material, the anterior chamber doesn't detect this as a foreign body. That's why you speak to any of the ICL surgeon. There are ICL surgeons where we do ICL within just 1 minute to 4 minute surgery. But majority of the times the eye almost remains very quiet. You can't even see a minimal bulbar congestion. That's how it is non-inflammatory. All credit goes to fibronectin. And these collamers are negatively charged. When these collamers are negatively charged, they repel all the negatively charged protein materials which are present with the anterior chamber. There are studies to show that 20 years down the line, when we have explanted the ICL, you can't get a deposit of a single white material on this ICL metal. But whereas with acrylic materials, just like IOL, you do get all the deposits, because this collamer repels all the particles and you never get this deposition of these particles within this. And as I told you, there is 99% light transmission, because of which the total internal reflections doesn't happen whenever you are keeping ICL close to the normal crystalline lens. Next important thing is what I spoke about, the chromatic aberration. See, chromatic aberrations do happen when there is a difference between the refractive index, and more the refractive index, lesser the Abbe number, more the chromatic aberrations. It is almost near to the crystalline lens. That's why the patients do not suffer from chromatic aberrations also. See here, whenever the phakic material is made up of acrylic material, this acrylic material refractive index is slightly higher. That can itself induce the aberrations, but collamer doesn't give a chance for all these materials. Next, coming on to cataractogenesis. Even before the availability of central flow, the induction of cataract with ICL materials was very, very minimal. That too, if at all, if it happened, it was typically the butterfly-shaped cataract which would happen at the periphery, where the foot plates would go and sit on this thing. With the availability of central flow technology, I myself, in my experience, have seen till date not done a single cataract surgery, and even the literature tells the same. It is non-cataractogenic in nature, except for the patients very high myopes, where you could see a second degree of trace PSC can expand, but as such the typical butterfly touch cataract is very, very minimal. Coming on to the endothelium safety, this is hydrophilic in nature, very flexible. Even if the surgical time is 2 to 3 minutes also, the surgical maneuver is so simple, the amount of damage because of surgery happening is very minimal. The endothelial count loss is very insignificant. So there is no significant endothelial cell loss when the patients get operated for ICLs. The wide range of correction, we can operate until -18 and -4 to -5 amount cylinders. And the confidence of this material gives me also to take up and do ICL surgery for the patients who are LASIK rejects as thin corneas, very high myopes. I do a combination of bioptics also. Post C3R patients, I confidently go and do. Post PKP patients, when there is refractive surprises, I confidently go and do the collamer ICL surgeries. The recent trend, last 3-4 years, I have started offering even ICL as a primary procedures for low to moderate myopias. All this confidence comes because of this material. Coming on to the design, you can see there how the posterior shape, what has been made. There's a central flow technology. There was a complaint initially when the central flow came that is there any issues with clear halos and all. If at all, this halos which appears for 7 to 10 days, with time it disappears. With availability of central flow technology, believe me, since 2015, not even a single intraoperative iridectomy or post-surgical iridectomy has been done by me or at my center. This central flow works so beautifully. And the most important thing I always tell is, I make sure that we need to wash the visco, whether HPNC or sodium iodinate, what you are using intraoperatively. We spend around 1 minute to wash away all the things. The spike will never exceed 21 or 22 millimeters of mercury. That's how the central flow works. And the biggest advantage with the recent days ICLC is the optic zone has been expanded by 0.3 millimeters. From -1 to -14, these lenses are called as EVO plus lenses. Even the pupil size around 5.5, still I confidently go ahead with EVO plus lenses because the optic zone has been expanded by 0.3 millimeter. Until 14 to 18, it remains the same. But -1 to 14, yes, we are made available with this expanded lenses. Because of this material and this design, so many thousands, lakhs of implants have happened worldwide. And because of this design, this material has stood so strong for the last 20 years. And the new trend is, it is going to begin a new era for low to moderate myopias also. So to summarize, Qualamar is the most and the highly biocompatible material which provides good quality and quantity of vision, and it is the ideal material for phakic IOL. Thank you.
Dr. Anand.
Yes, sir.
It was a wonderful, description about the design and, why you prefer the lens,
Yes.
and it's over the years, so many implants have been done. Thank you very much.
Yes, sir.
Any questions that any of you would like to raise? Kindly accept this gift from KSOS. So the next speaker was supposed to be Dr. Mathew. I have gathered his slides. I'll just mention a few points on the fitting of the ICL in the right patient. So just a few slides I'll talk upon regarding his topic. So as you all know, the fitting of the lens is very important. One can't go wrong with that because, as you know, the vault is highly specific. Like you can't go beyond one and a half thickness of the cornea. So it's something like 900 microns. Beyond 900 microns, the vault is too much. And if it's too less also, it's going to cause cataract, and the lens might move around because it's a loose lens that is going to be fitted in. So what we normally follow is the measurement that you take on OCT, or earlier, like, we used to use the preliminary measurements that you get for your LASIK. There also you used to get the white to white. So this, along with the manual measurement of white to white using a digital caliper, that is what we depend on. And these are the two measurements we take. And then when you do the measurement with the caliper, actually we repeat it at least 3 to 5 times and then take an average of the white to white. And then with the refraction and the details regarding the anterior chamber depth and white to white, you send it to the company and they provide the different options along with the correction that is possible. So here you can see what is the vault that is mentioned. It's the distance between the crystalline lens and the posterior surface of the lens, the implant. So it should be ideally around 600 microns, and anything beyond 1000 microns is high vault. You can see the iris is pushed forwards. So what happens is the endothelium can get damaged, pigment dispersion could be there, and also angle closure glaucoma is a high possibility. So such high vault lenses, better remove it and correct it with the right kind of size of the lens. So low vault, as already mentioned, can cause cataract, decentration, because the lens will be loose in the sulcus, and also it can cause rotation of the lens. So if it's a toric spherical correction, I mean lens that you're using, often the power correction also will go haywire. So this is the graph, I mean the table showing what all extent one can go. So it's the reference point is the corneal thickness. So anything like 1 to 1.5 thickness, times the thickness of the cornea is quite acceptable. And anything like by 1/4 or more than 2 times the thickness of the cornea, then either it's a low volt or a high volt lens. So this is the caliper that we use. This is a digital caliper. It's around 5,000 rupees if I remember right. We do it in the theater, make the patient lie down on the table, and it's done under the microscope. Take 5 measurements, and then the average of that 5 will give you the final white to white. You should be careful because the external imaginary limbus, wherever you're taking can differ. A 0.25 and 0.5, difference can occur. So keep repeating, try to get the similar measurements, and then out of the 5 measurements you take the average. So 4 models of the lens are available. The different lengths of them are available, and these are the combinations that you can go for. Anything less than 10.5 white to white, you don't go for an ICL, and anything above 12.5 or 13, like those are also not recommended. So this is regarding the measurement that you should do. These are simple things that can be followed, but then you should be very careful, and the surgeon himself has to do this before you order for the lens. And usually the lens takes around 2 weeks, or if the lens is not available locally, it might take a little more longer. So all that has to be planned when you're doing a phakic IOL, especially ICL. Okay, thank you. Next is Dr. Jayaram. He'll be talking about his experience with star ICL, procedure and the complications.
A very good morning to everybody. At the outset, I would like to thank Dr. Jacob and KSOS for giving this opportunity to talk here. Actually, Dr. Jacob has asked me to talk about my experience with RSL, the procedure and complications. So this is a Cochrane database study which was published recently, which compares LASIK and phakic IOLs for high myopia. So there are 3 points they have highlighted. For high myopia, initially, even though the vision was good, over a period of time, the patients who underwent LASIK had a deterioration in vision. And the patients who underwent phakic IOL implants had a better contrast sensitivity, and the patient satisfaction indexes were better with phakic IOL. So it is definitely the preferred treatment for higher myopias. So coming to star ICLs, Dr. Anand had already gone through the design, so I won't be going more into that. So the material is as highly biocompatible polymer material, and it has less internal reflections, UV absorbing. So when you do the procedure, the important thing to note is like that holes on the leading haptic in the right and the trailing haptic in the left, so that you don't implant it in an inverse manner. This is already mentioned by Dr. Anand. So coming to the surgical technique, actually you have to pull the lens this is a V4B, not the latest model. So, and then you have to put it into the nozzle. Sometimes it's a little bit sticky, so you slightly manipulate and that will come out. Then two parasynthesis. You can put some intracameral lignocaine for intracameral anesthesia. Put dispersive viscoelastic. Never a cohesive viscoelastic, which is very difficult to remove. And with star ICL, at least 3 millimeter should be the main port. Maybe a slightly more will be easier for you to do. Then while injecting, should be very observant how the lens is coming out. So when it comes out, that should be, that leading haptic should be in the right with the hole, and the other one should be in the left. If there is, you have any doubt, then you before completing you can pull it out and then do a re-implantation. Reload the lens and put the lens again. And then after putting it in the AC, then put some visco over the ICL. Then tuck the haptics behind the iris through the side ports. There are especially in the iris lens manipulating instruments which has some grip on it, with which you can nicely do that without causing much of a manipulation. Then nicely wash away the viscoelastic. This is a V4B, so in this video there will be a PI. I will be doing a surgical PI with a vitrectomy probe. Actually, this removing the viscoelastic is very, very important, because it this is actually I'm doing the PI with the vitrectomy probe on the with a low cut rate. Then wash again the visco again, then hydrate the wound. So the steps are important. Proper loading of the ICL is very important. Then put to parasynthesis. Initially, it's always better to use a intracameral lignocaine. Then viscoelastic injection, injection of ICL, visco on the top of ICL, position of ICL behind the lens, and removal of the visco. So intra-op complications are the main problem that can occur is the ICL inversion, which you can usually manage initially while injecting itself. You can see that if it's going inverted, then it's better to, if it is possible, you pull with the itself out, or if it's already gone, then you can either use, I use a McPherson or the lens holding forceps also. You put a little visco behind the lens and then slightly rotate it and hold in the plate part, not on the haptics, because haptics when you pull it will stretch and it tends to break and may not come out easily. And if there is any damage, then it's better to replace, avoid endothelial and lens touch. Once in one case I had a IOP hike intraoperatively. I couldn't do the PI. Means it's very difficult to get into the periphery, so I had to do quick PI near the main port itself, but it went on well later, and the patient was okay. Postoperatively, the IOP is high, and then you can give acetazolamide or burp the side ports. Volt, as told, 0.5 to 1.5 corneal thickness is the best. Beyond that, you should be careful. If it's very low, it's better to, it may induce cataract. If it's very high, it will cause endothelial damage. If there is more of inflammation, you can increase the steroids. Degeneration and implant rotation can happen if the sizing is less, then we'll have to manage accordingly. Actually, as Anand told, the amount of post-op complications was less. I have done around 1,000 ICLs, but 2 cases I had end of. One was a delayed end off after 3 years, which initially was treated with intravitreal antibiotics. He was better but not completely cured, so we had to do an explantation with vitrectomy. After that, it was settled. The second case was a 1 month post-op case presented with pain, redness, and decrease in vision. But in that patient actually hide that the history of diabetes. So she was on control when she came for the pre-op, but didn't tell that she is taking medications. So after the surgery, it became uncontrolled, and then she developed end off in one eye. So her blood sugars were controlled. She responded to intravitreal antibiotics very well, and the ICL was retained. And retinal detachment is really a problem with these patients, because most of them are very high myopes. So you should be careful with the follow-up. 2 patients had retinal detachments, but via surgery was done, and actually the ICL was retained and patient was okay. Cataract is also very rare. I have done 2 cases of cataract with ICL explantation because of low volt. Because over the time the volt decreases due to the increase in size of the lens. So in borderline volts, over time cataract may develop. In such cases, if it becomes significant, then you will have to do an explantation and cataract surgery. Other complications are glaucoma. High myopes already have a tendency to develop glaucoma. And post-op diplopia in unilateral high myopes always do a contact lens trial to see whether there is diplopia. High and low volt already mentioned. So to conclude, star ICL is an effective treatment for high refractive errors. The latest models are easy to use and can be implanted by experienced cataract surgeons. We foresee obviated need of PI, thus making the procedure more simple and reduce the incidence of cataract. Through pre-op evaluation, adherence to criteria is important for a good post-op result, and periodic follow-up with education of patient should be emphasized for early detection and delayed complications. Thank you.
Thank you very much, Jairam. What was the reason for the late onset of endophthalmitis, the 3-year?
Must be endogenous endophthalmitis.
Okay.
Not related, that's why I told you. It's
Yeah.
not related to the ICL as such.
Oh. And then how do you take your white weight? You had mentioned to me yesterday, but then for the benefit of the audience here, how do you take your white weight?
White weight I take with the caliper, with the measurements, as well as we do have an anti-ion in which you can measure the spot to spur distance. You can compare it and see. And ideally, UBM is the gold standard, but it's difficult, and everybody don't have the access to that. But it usually with the white with calipers work very well.
Thank you very much. So that was highly expert hand, having done 1,000 ICLs. Those were golden words that we heard from Dr. Jairam. So the next topic is by Dr. Jason. He has used plenty of IPCL. Those are the Indian implantable contact lens that is available. Cost factor is a major issue. So all patients can't afford the star ICL. So this is a good option that surgeons like us have resorted to. So Dr. Jason is going to talk about the Indian implants and his experience regarding that.
Good morning all. I'm going to talk about my experience with Indian implantable contact lens. So I have done only 93 IPCLs of 51 patients for a period of 7 years. You can see initially we were using IPCLs without holes, 34 without holes, and later we started using IPCLs with hole. You can see toric is outnumbering non-toric lens, 55 toric, and the lowest diopter implanted was 3 diopter, and the highest was 22 diopter. And regarding the results, we got 80% got uncorrected visual acuity 6 in 3 months. And 90% were within 0.5 diopter of spherical equivalent, and 98% were within 1 diopter spherical equivalent after 3 months. And 97% of eyes attained or improved their pre-operative best corrected visual acuity. These are the measurements what we take for IPCL implantation, refraction of course, and K1, K2, ACD, anterior chamber depth, the lens thickness and axial length from IOL master. When we do topography and take corneal thickness, and this corneal thickness has to be reduced from the chamber depth obtained from IOL master to get the depth from the endothelium to anterior lens capsule. And ACD less than 2.8 is avoided from implantation. And white we still are using the caliper, manual electronic caliper. We are not using, not started using the OCD based angle to angle measurement. And online power calculator will provide you the IOL power. And we have to see the endothelial cell count and IOP for all cases. And there are only 2 steps you have to be careful about implantation. That is, one is loading and the other one is haptic placement. What I do is I make a pocket with the viscoelastic beneath the iris so that I get a space there so that I can easily implant the 4 haptics of the lens. Initial days we were using this without hole lens, so I used to go beneath the IOL and wash the viscoelastic. And these days that is not done because the central hole, through the central hole you can aspirate the viscoelastic. And initially we were not having the central hole and we were doing the iridectomy. I used to do all intraoperative iridectomy. And initially I used to put pilocarpine also. So and this is the only intraoperative complication which I got, that is the lens went upside down. And these lenses, when it goes upside down, it is difficult. Unlike your PCIOL, your capsular bag space is not there, and turning the lens is extremely difficult, and it has to be done very carefully with viscoelastic coverage. So that was the only intraoperative complication. And other issues were anterior subcapsular cataract. Two eyes developed anterior subcapsular cataract, and one was a 32-year-old patient, 17 diopter implanted patient. Another one was 25-year-old 11 diopter implanted person. And both were having no central hole at the, for the IOL. And the lens vault was adequate. And the first patient, cataract developed within 1 year of implantation. Initially, vision was okay, but within 16 months, it became 618. So surgical intervention was done for that patient. And vision improved from 618 to 69 after surgery. And the second patient developed anterior subcapsular cataract following an RD surgery. That video I will be showing later. And this is one thing where your implantation is more difficult and explantation is so easy actually. Through the tunnel, you don't have to enlarge your tunnel. This lens will come out through the tunnel. Maybe the other star lens will be easier than this IPCL. So still you can explant the IOL through the same wound. The other complication was increased intraocular pressure. 4 eyes of 3 patients developed increased IOP, and 3 were without hole and 1 patient was with hole. And IOP was always within, below 30 in 3 eyes. And these 3 patients developed immediately after surgery intraocular pressure, and they were managed conservatively with medications. And we could remove all medications in 1 month. So out of 4, 3 was easy to handle. But the 4th patient developed intraocular pressure following RD surgery and IOL RD surgery and silicone oil implantation. But the cataract was not like as you get in silicone oil implantation. This developed after 7 years after implantation, and it was not like the cataract that you get in silicone oil implantation. It was like a anterior subcapsular cataract, that what you get in implantable contact lens. So this patient had intraocular pressure also. So this lens was slightly more difficult than the other lens, but the what you call the exchange of hand technique, it was removed. And it was combined with trabeculectomy because the pressure was very high, above 50. So trabeculectomy was done for that patient. Patient is still under follow-up, and time being the pressure is normal. And this is the other complication I had with implantable contact lens, that is rotation of lens within the sulcus. This patient presented 14th day of postoperative, 14th postoperative day, and this was repositioned through a paracentesis without a viscoelastic. Actually, maybe white-to-white issue was there. That may be the reason. But fortunately, this lens remained there after that. So the vision, I could regain, that patient could regain the vision. So to conclude, significant reduction of myopia and astigmatism were achieved in all cases. Anterior subcapsular cataract and raised IOP was the most frequently seen complication. And whole IPCL decreases the risk of cataract formation and raised IOP. Thank you.
You didn't mention about the mark on the haptic when you inject the lens. IPCL.
Yeah, actually, you mean the haptic marks? Somebody else mentioned that trailing one should be on to your right hand, the leading should be to your left hand.
What is the lowest spherical correction? Why did the patient opt for ICL? Three spheres what you corrected, no?
Yeah,
Minus
that patient, corneal thickness was too low. It was not fit for LASIK. And patient was very keen on spectacle freedom, so we implanted 3 diopter.
Thank you, Jason, for your wonderful talk and your experience on IPCL.